Hello, my name is Dr. Diane Danley, and I'm board certified in family medicine, and I've done palliative medicine for the last 8 years. I'm also board certified as a hospice medical director. And it's my pleasure today to come to you and speak with you about serious mental illness in the context of advanced medical illness. And the title of this talk is Serious Mental Illness and Advanced Medical Illness. We're supposed to do what? So the objectives today are to identify and describe the risk of advanced medical illness in those with serious mental illness, to discuss the ethical aspects and practical challenges of providing adequate medical care to our patients, to explore barriers to effective disease-modifying interventions in addition to palliative interventions, to describe and discuss what shared clinical decision-making is, and to describe the effective use of a pulse as a tool to communicate goals of care throughout care transitions in patients with advanced medical illness. So thank you for this today. The disclaimers and definitions. This presentation is being offered by Eastern State Hospital for educational purposes. It's not supposed to be a substitution for medical advice or treatment, and I have no disclosures. Just to touch base before we kind of get launched is some of the abbreviations I'll be using. So HRQOL is equal to health-related quality of life. AMI will be advanced medical illness, and SMI is serious mental illness. So this is just a question to the audience. How many care for patients who have more than one advanced medical comorbidity? And how many care for patients who may die in the next year or two? Well, that's a lot of us, isn't there? So why are we talking about this? Well, first of all, 6% of the population in the US have serious mental illness, and 1 in 4 will have a serious mental illness that occurs annually. But 1 in 17 live chronically with a serious mental illness. The mortality rate in those with serious mental illness, people die much younger. Women die 10 to 18 years younger than the general population. Now, if you're a woman who's born right now in the US, your average age of death is around 81. However, if you have serious mental illness, your average age is 67. Men die 8 to 19 years sooner than general population. Right now, if you're a man born in the US, you expect to live about 76 average. However, if you have serious mental illness, your age expectancy is around 63. The majority of the excess death is attributed to cardiovascular disease, and especially heart disease, a disproportionate amount of heart disease, respiratory illnesses, and cancer. Many of you may have guessed that it might be related to suicides or accidental or violent deaths, but that's actually not the case. It is an unusually high level of especially cardiovascular disease. And despite advancements in medical care, patients with chronic serious mental illness, such as with schizophrenia, they're not benefiting from the advances in healthcare to the same extent as the general population. And I don't know, that's pretty upsetting to hear, I'm sure. So what is going on? Well, if you actually just sit back and you actually measure the amount of risk that's imparted when someone has serious mental illness, there is between 2 to 3 times the risk of having smoking, diabetes, hypertension, and metabolic syndrome in serious mental illness. And surprisingly, despite the medications, hyperlipidemia isn't as increased, but obesity is. So up to twice the risk of obesity. Now, how much of this is related to lifestyle issues? Well, it's not all. They're actually when they've controlled for lifestyle issues, such as smoking, lack of physical activity, those things did not play a role. So there's something inherent about serious mental illness. So having serious mental illness means you have 2 to 3-fold times the risk of having more health problems, especially chronic. And 26% of those with mental illness also meet the criteria for a substance abuse disorder. I'm sure that's not surprising, and many of us would probably think it's higher than that. Mortality rate for schizophrenia is twice that for the general population. And as I mentioned before, controlling for behavioral factors such as smoking and drug use does not impact the heart disease-related mortality. What are some of the barriers to treating medical conditions in those with serious mental illness? Well, I'm sure as I ask the question, there are many that come up to you in your mind as you've dealt with this. Lifestyle factors such as substance abuse, diet, lack of exercise, obesity, side effect of medications, the effects of illness over time, cognitive impairment, social isolation, and lack of family support. Pain response. Now this part, when I researched this, surprised me, but in general, those with serious mental illness have an impairment in ability to adequately relate their pain levels. And they've been thought either to have a higher pain threshold, a reduced sensitivity to pain, or I suspect more likely, a reduced reporting of pain. So these folks are at real risk for having uncontrolled pain. So what are other factors? Well, suspiciousness and fear, self-neglect on the part of patients, lack of motivation, socioeconomic factors, and impaired ability to communicate healthcare needs. What is wrong system-wide? Or what are things that are barriers system-wide? Well, I know this is not going to surprise you guys, but mental health is not well funded. Patients are less likely, who have serious mental illness, less likely to receive interventions such as coronary bypass graft with 3-vessel coronary disease. They're much less likely to actually have arteriography after stroke or to have their diabetes optimally managed. Out in the community, there's also a lack of care integration and coordination between the mental health system and medical issues. Provider barriers. Yeah. The stigma of serious mental illness. And I have to say that there's a lot of, our medical school training is not adequate to help prepare our residents or our primary care docs to develop a level of expertise and strategies by which to deal with this. There's the stigma. There's time and resource constraints. People with serious mental illness require a lot more time, a lot more patience, and a lot more coordination. Physical complaints may be seen as being psychosomatic. Oh, this person's got serious mental illness, so is this a psychosomatic result or symptom? Then there's the worry about worsening drug use. For example, drug misuse with narcotics and those with previous narcotic addiction or abuse. Then there's fears that we have about actually talking openly with our patients who have serious mental illness that keep us from bringing them up, thinking that maybe we'll make them unstable or contribute to their psychosis. And the first, and I think the most important problem we actually have, and one that's probably the most amenable immediately, is not having adequate training in how to have these conversations in general, whether you have serious mental illness or not. Those with serious mental illness who have advanced illness, they are stigmatized times 7 and more. You know, they have serious mental illness. They're dying, or they're elderly. They have memory impairment. They're poor. They often are disenfranchised by family or society, and they're at real high risk for demoralization syndrome. What demoralization syndrome is, it's looking back at your life and during particularly your psychotic episodes, having shame and remorse and not being able to shake that and have that really haunt you at the end of your life. So these are very important issues that are unique to this population. Well, I think a lot of us may wonder, can people with serious mental illness make medical decisions? And so this is this particular slide, which is slide number 15, demonstrates that persons with serious mental illness are often not afforded the opportunity to make decisions like those in society can. But serious mental illness is considered a disability. People with disabilities should have equal recognition before the law and the right to exercise their legal capacity. And that means being able to make decisions about employment, medical or psychological treatment, property, finances, family, etc. So this is essentially a major issue. And I understand there's that ethical burden of what to do with people who are psychotic, and we're going to talk a little bit more on this next group of slides. So let's now delve into the ethics of decision making. What is informed consent? Just to kind of lay down some basic principles. I'm sure you guys are familiar with these things, but first of all, informed consent means the person is able to make free any decision they're able to make with no coercion and no negative consequences or result or recourse that would be negative to them for making that decision. That number two, the patient is given all the information in a language that they understand and that makes sense to them. And that the person is an adequate decision maker. They can reason logically about the decisions, be able to balance the risks and benefits, and be able to express a consistent choice. And I want to make a big point here. There's a big difference between decision-making capacity and competence. Okay, decision-making capacity means, does that person understand, appreciate, reason, and are they able to express? So let's look at each one of these four things. Are they able to understand or comprehend the information about the nature of their condition, the procedures, and are able to understand the risks and benefits? Are they able to appreciate the significance of the disclosed information? And are they able to apply it to their own situation and their condition? Are they able to reason? That is, it means participate and engage in a logical reasoning process that can be followed by others when looking at each of these risks and benefits, so they're able to weigh these things. And are they able to express a consistent choice? That is decision-making capacity, and that you'll find in the New England Journal of Medicine 2016. Competence, on the other hand, is completely different. Competence is a legal determination made by a court of law. While a court may consider information about a person's or a patient's decision-making capacity, that doesn't mean that competency equals decision-making capacity. And I just want to say that oftentimes our patients are partially decisional. They're able to participate in some way in decisions, perhaps expressing values, fears, where they may not retain their complete capacity. And we'll go through that a little bit more in the ensuing slides. Now we're going to go through the four basic principles of ethics and how it relates to making medical decisions. Well, there are four basic inherent ethical principles are autonomy, which is the ability to self-rule or to have human dignity. Beneficence, which is to bring good about with our actions, to really intentionally do everything we can to bring out the best outcome possible. Justice is to treat all people as though they are worthy and equal of care and respect. And non-maleficence simply means not intending harm, but also trying to minimize the harm that happens. So models of decision-making in advanced medical illness. So on the left side of the slide, you'll see the grayed out sections. And one is the first one on the left upper corner is the more paternalistic approach of traditional medicine, which is the patient comes in, they listen to the doctor says you have this illness and you are going to do this. And the patient says, okay, that's what I do. So that's clinician-led medical decision making. Then there's the patient-led clinical decision making. Perhaps the patient saw an ad on the TV saying, I want this particular drug, comes in and said, doctor, I want this drug. The physician said, okay, writes the prescription, hands it over. That's a good depiction of that. On the right would be probably more preferential forms right now for decision making because of improved outcomes and patient satisfaction. Shared decision making is when a patient and a medical practitioner get down, they have an honest conversation about what the treatment options are, what the medical condition is, and about what are the options, what are the risks and benefits. So that's shared decision making, and then there's a conversation between the two and they make the decision together. An example of this would be the Choosing Wisely campaign by the Society of Internal Medicine, which has helped us get rid of unnecessary tests and procedures. the other one is supported decision making. And by supported decision making, what we're trying to say is the patient is given as much autonomy as possible with support of an identified durable power of attorney for healthcare or guardian. And the whole idea is, how do we take as much input that's useful from what the patient is saying and support them through the next decision-making process that's in line with what we understand their goals and values are for their life. And as we know, people with serious mental illness, they can wax and wane in their decisional capacity. And so this is an ideal way to do it, because then you always have the backup support of the guardian or power of attorney. And as you notice at the bottom of the slides, that there are certain times where different approaches may be appropriate. So in terms of, they've actually looked into this, there's been studies that have been done that have actually looked at outcomes and investigating each of these models. And the shared medical decision making regarding tests, procedures, and treatment, it ends up being more accurate and informed consent. But shared and supported decision making ultimately ended up with improved patient satisfaction, improved treatment adherence, and improved health-related outcomes, including symptoms being better managed. So I think that we can kind of say that shared decision making is a good way to go, especially if someone has the capacity that fluctuates. And palliative care just happens to be a model of shared and supported decision making. What is palliative care? And I'm sure you guys have heard of this before, and it's becoming more and more well known. It's specialized medical care for those people with serious medical illness. It focuses on providing relief of symptoms and the stress of serious illness, supporting the patient and the family. And the goal is to improve quality of life for both the patient and family. And I just want to say that on the bottom part you'll see of the slide, if you'll notice, it says all work together to provide an extra layer of support to the medical team and to the patient and family, and is appropriate at any age and any stage in a serious medical condition, and can be provided along with curative treatments. Let's really say that again. Can be provided along with any curative treatments, as long as it's in line with what outcomes patients are desired for and are consistent with the patient's goals and values. So I think we need to really step away from that whole curative or palliative treatment. Yes, those terms are correct when they're used by themselves, but in a sense, the treatments, when people have advanced medical illness, they begin losing their effectiveness. And it depends on where a person is on their trajectory of their illness, of what their likelihood of responding favorably. As you know, a person who's sicker oftentimes has the increased risk of having a worse outcome than having a favorable outcome. And that needs to be shared individually, depending on where that patient is in the course of their illness. And I think we need to really take away from, the one takeaway I would ask is, please quit looking at things as curative and or not curative. Look at things of how they serve the patient in terms of their goals of care, recognizing that there are many illnesses that are chronic progressive illnesses, and that these folks require an approach that takes an individualistic approach that fits them. It's almost like being fitted for a particular outfit or costume. It has to fit them, who they are, where they are with their medical condition, and who their family is and what their social situation is. So specialty palliative care is provided by a trained team of doctors, nurses, social workers, and other specialists. And they simply bring another layer of support and can help particularly with difficult cases. So this is from the University of Washington School of Medicine, and you see the link there. And this is a model of how palliative care can be incorporated ideally. You know, as your life progresses, you have preventative care, you try to do a healthy lifestyle, and then you're diagnosed with a progressive illness that is serious. And so what happens is, initially there's a lot of life prolonging or curative attempts that are started, but palliative interventions are also initiated. For example, people who have been diagnosed with cancer that then get antiemetic therapy while they're getting their chemo. That's all it's all toward trying to make that person have the best quality of life through their treatment. But as time progresses, their illness progresses, those curative interventions start to lose their effectiveness. And as that happens, then more focus on symptoms, more focus on empowering the patient to have control in their own lives and the family to have more control in their own lives. Working at what are the things you're trying to get to. For example, I want to walk my daughter down. I want to walk my daughter down, and while she gets married, I want to give my daughter away. So those are like examples of things that become very helpful. And then at some point, those life-prolonging or curative treatments, as we like to hear about them, they no longer are effective and in a sense become burdensome and cause more problems and actually can shorten a person's life. And at that point, that's when end-of-life care is provided.